had a couple moves since 2017, but now I'm just at 8th and Hemlock. There's a medical derm office, combined cosmetic dermatology office called Pacific Derm. Jason Rivers is sort of the senior dermatologist, and then Marcy Elmer, Diana Diao, and Vincent Richet are there as well. Mm-hmm. 4. I'm here 1 day a week, and I occasionally go to Whistler to do a visiting specialist clinic. So once a month I do that, go skiing. Yes.
It saves people travel.
It does. It does. They're very appreciative, and yeah, it's good. The government pays you a little extra to go and do that. So it is. It is. Yeah. No, it's good fun.
And so when you're in the other clinic, is it a mix of like medical and aesthetics?
I do zero aesthetics. I don't even cut skin tech still. Yeah. I didn't get into it, and very few. But I enjoy what I do. And yeah. Yeah, it's tough. We train these great clinicians, and then they get, cosmetic dermatology, you make a lot of money and you make a lot of people happy. The people are coming to see you, not because they're sick. They're coming to see you because they want to improve on what's going on. So it's a different population, not even patient, they're clients, right? And you have to know how to sell beauty, and that's just not who I am. So you're itchy, I'll make you less itchy. I will help with that. You have a skin cancer, I can take that off. Oh boy, can we help.
Okay.
Sure. Yeah, I'm out of practice. Okay.
So mic is on.
The mic is on.
Yeah. Yeah. Yeah, no worries. Yeah, okay. Usually the only thing I is that the people who call in and turn up the phone, I don't have control over kind of muting everybody.
Yeah.
So I guess we'll just put everyone on mute.
Yes. So Gillian, there may be periods where people will call in. They will not.
Mute, yeah.
So they might have to just ask.
Sure.
Yeah.
I'll try and remember that. Yeah.
Yeah. That's like a fish. Some pinch like the feeling. But
good afternoon, everybody who's on Zoom. I just ask you to mute your mics. If you can remember to do that, that'd be great.
it's not a very pleasant thing to do.
Excuse me, whoever's on, can you please mute your mics? I'm not sure that I have.
I just don't know how to bring up this.
I don't know how to either. Okay, so we'll be intermittently reminding everyone to mute their mic. Okay. And then when we have questions, we can. Okay, we'll unmute it. Okay. Okay, that's actually good. Okay, right. Okay. Okay, it's 12:01, so we'll get started. I just wanted to welcome everyone to Medical Grand Rounds. It's March 14th. I'm Anita Pelko. I'm the head of the PHC Department of Medicine, and today we're gathered and grateful to be on the ancestral, traditional, and unceded territories of the Coast Salish First Nations, the Musqueam, Squamish, and Tsleil-Waututh. And we as a department are committed to the Truth and Reconciliation Commission's call to actions, and also in responding to the In Plain Sight report. I think it's a big commitment that we have. And so we are grateful to be on these lands and For those who are around the province calling in or being on Zoom, please reflect on the territories that you're on. So it is my pleasure to introduce Dr. Gillian de Gannes, and her topic is allergic contact dermatitis. Gillian has been with St. Paul's for many, many years. She's a clinical assistant professor, and she works at the contact dermatitis clinic, and she's also the director of this clinic. And then she works outside of St. Paul's the other 4 days a week, entirely does medical dermatology. So we're really lucky to have a dermatologist that is exclusively doing medical dermatology. So I already praised her for that. So not that I have anything against cosmetic dermatology, but I am grateful for your expertise and commitment to medical dermatology. So without further ado, I will hand it over to you. Thanks, Gillian.
Anita. So I'm just going to put my stopwatch on here so that we don't run over. So thanks for the invitation. I joined St. Paul's Hospital in 2007 after I graduated from my dermatology residency here. I also used to be a family physician, and I trained at St. Paul's Hospital doing my 2 years of family practice from 1999 to 2001. So I'm going to talk to you a bit about what my passion is, and if I could do contact dermatitis 24/7, I would, but I own a house in Vancouver that has a mortgage attached to it, so I've got to do other stuff. But this is my fun day. I have some disclosures. This is over the last 2 years. I've either been a speaker for or on advisory boards for these particular pharmaceutical companies. The one I've highlighted in yellow has donated to the St. Paul's Hospital Foundation, which is part of how our contact dermatitis clinic was run. So I'm going to go over our PHC Dermatology Center. We get a new name every few years. Contact Dermatitis Clinic. I'm going to update you on it. I'm going to talk about severe cutaneous adverse reactions, which you in medicine will see in hospital patients, and answer the question, is patch testing helpful in identifying the culprit drug? And then I'm also going to talk about around the surgical procedure, allergic contact dermatitis, and what some common allergens are. And this all comes from the clinic that I've been involved with referrals from our colleagues in medicine and surgery. So the contact dermatitis clinic here at St. Paul's Hospital started up in 2016. We were in 5th floor Burrard rapid access space, and it started up with a generous donation from a grateful patient through the St. Paul's Hospital Foundation, with the sort of mandate to say, we want to keep this clinic running. We want to prove that there's some benefit to having the clinic. And now, as of, I think, November, we are a line item in the hospital budget. So we are here to stay. These two companies, Gillian and Sanofi, also contributed to some of the funding as well. So there's 3 of us at the clinic. I'm the director. My assistant, Brenda Shadell, helps with all the patch testing, as well as being my research assistant. And then we have a shared nurse, Rashmi Singh, who is, a lot of people will know her from her other roles. We patch test about 10 to 12 patients per week, and we have over 2,000 patients in our REDCap database. So when a resident comes through and asks me, how common is lidocaine allergy? And I say, that's a really good question. Let's dive into this database and pull that information out. Are people familiar with the REDCap database? Yeah, good. We have about 400 allergens stored in our fridge. So we are tertiary center, quaternary center for patch testing. I'm one of very few dermatologists who do this, and we do have some allergists who do this form of testing as well. The referrals come through dermatologists primarily, but I do get referrals from some of our allergy colleagues as well as our surgeon colleagues. And the dermatology residency program, being a 5-year program, 1 month per year of their last 3 years, they need to spend with me. And we encourage scholarly projects. So some of the publications I'll show you today are the scholarly projects that were encouraged while they were on the rotation. So I have about 300 plus referrals sitting at my primary office waiting to be seen. So it's about an 8-month wait once the referral is received at my office. So we are now booking June 2023 patients in my office. The dermatology resident sees the patient in my community dermatology office Fridays and Mondays, and they do a half-an-hour consultation. Imagine that, a half-an-hour consultation in an outpatient dermatology clinic, okay? From the time of the consultation, it's about 6 to 8 weeks before they actually get into the contact dermatitis clinic for patch testing. Right now, I'm seeing patients patch testing who were in consultation on the Jan 2024. WorkSafe BC patients are expedited. I will see them and patch test them within a month. We keep extra spaces for WorkSafe BC, so nobody gets bumped out of the line. Myself and my staff just come in earlier and leave later. So there is a PHC Dermatology Center referral form, and if anybody has a patient who actually has suspected contact dermatitis and they're a dermatologist, they can refer them to me here. But I also, like I said, get referrals through surgical colleagues as well as my allergist, and once in a while it comes from some other specialty as well.
I'm sorry, Dr.
So we have a
Gannes.
website, and it's mostly
Hello?
an information website for our patients. So part of the dermatology resident's 30-minute visit is they show the patients a PowerPoint presentation to say, this is what patch testing is. No, there are no needles involved. And yes, it takes a whole week, 3 visits over a week to see us. So if you've never heard of patch testing or what we do, on our first day of seeing the patient, which is always on a Wednesday afternoon at our clinic, we take allergens, which are over on the left-hand side there. Do I have a mouse? I do. So these allergens here, and they're prepared in a central place in Copenhagen, and they're sent off to us. We then take our patches, which is a center picture, which are little
Sarah,
foam
could I ask you
squares.
to
An
kindly
individual
please
allergen is placed in an
mute
individual
yourself?
patch, and then they're applied to
Mute
the
your mic.
patient's back, possibly their arms. Sometimes I've used their thighs, depending on how many patches we're putting on. Patient goes home at this time. They are not allowed to do any heavy upper body physical exercise. They're not allowed to get hot and sweaty, and they're not allowed to shower. Hence that preparation of us telling them all of that way ahead of time, so they know, hey, if I have a heavy job, I can't do it. I have to take that time off. They're back at the clinic on the Friday morning, which is just under 48 hours, and I remove the patches and I do the initial reading. So essentially what we're looking for is a perfectly shaped square that looks like eczema. They go home on that Friday, they can shower, exercise, get hot and sweaty, but they're back again to see us the following Wednesday morning for the delayed reading, because as you all know, this is a delayed type 4 hypersensitivity reaction that can take days to show up. So when we see them, this is what we're looking for. So this is the morphology we're looking for. On the far left, no reaction on the skin. On the far right, a 1 centimeter by 1 centimeter fluid-filled blister. That's our most severe reaction. 90% of the people, when they have a reaction, we are just seeing this, erythematous papules that are infiltrated. And that's by design. The choice of how much concentrated allergen you put on the person's skin is to achieve just a 1+ reaction, to say, yes, they're allergic, and not necessarily to create a blister, but sometimes it happens. So I'm going to talk about severe cutaneous adverse reactions, and is patch testing helpful in identifying the culprit drug? So many of you may be aware of what we call our MedSafe clinic. It's a combination clinic with allergy and immunology, Dr. Mack and his fellows. Bruce Carlton is at BC Children's Hospital. He's a clinical pharmacologist. Dr. Marisa Ponzo helped to start the MedSafe clinic, but Dr. Ponzo, the dermatologist, moved back to Ontario. And so Dr. Sheila Au has stepped in, and Dr. Jan Dutz participates when he is around and able to. And then I was invited to participate as well. So essentially, what the MedSafe clinic mandated is to help clarify culprit drugs in these severe cutaneous adverse reactions, especially when the agent is unclear. There are a number of different assays that are used, and I'll be talking to you about patch testing. The clinic also has other mandates of supporting people for counseling and following for long-term sequelae from their severe reactions. So I'm going to talk about generalized fixed drug eruption. This is a 23-year-old woman, and she was taking repeated courses of fluconazole, especially because she thought she had recurrent yeast vaginitis. In Feb 2020, she had some lip swelling, blisters and erosions, and a skin eruption. And then in September 2020, she presented with a widespread eruption requiring hospital admission. And so these are her photographs. She's got a erosive dermatitis on the vermilion surface of her lips. She has inside the mouth mucosal involvement. And then these pictures that she provided us, a widespread, dusky, infiltrated plaques and papules scattered over her trunk and extremities. So fixed drug eruption, as you may remember, again, a type 4 hypersensitivity, fixed because the eruption tends to come in the same place all the time. So there are lovely T cells that have memory sitting in the skin. You can see on her arm here, there's some hyperpigmented areas. when we do testing for fixed drug eruption, we have to put the allergen in the area where the fixed drug eruption was. And you guys might remember that fixed drug eruptions often come up as a single circle on a genital area of skin. So yes, we've had to test genitals at times, but fortunately we can sometimes find spots in other places. So in this woman, I patch tested her to the actual oral medication she took, Gannes oral. I patch tested her to another version of fluconazole just in case it was something in the Gannes product. And I also tested her to itraconazole in case in the future she truly did have yeast vaginitis and she needed to use another medication. So the patches were applied, and 48 hours later, they were removed. And I'll show you a close-up here. So these patches on the upper part were all of the fluconazole dilutions, and this was her itraconazole. So positive patch test reaction at the 48 hours for fluconazole, negative for the itraconazole. And at that time, the allergens were being prepared by our compounding pharmacists. And sometimes with medicines, we don't have set allergens that were available to us. So I'd use McDonald prescriptions. They compound into certain vehicles. And we were testing to 10% and 30% product in both petrolatum and aqueous to say what was the best one that would penetrate through the skin. So in her case, all of the fluconazole dilutions showed positive reactions, both at her 48-hour read and her delayed day 8 read, with negative reactions to itraconazole. Acute generalized exanthematous pustulosis, or AGEP. You will see this in your internal medicine managing of patients. This is a 40-year-old man, typical hypertension, diabetes, bilateral below-knee amputation, chronic kidney disease, on dialysis 3 times a week. In October 2020, he had a fistulogram with IV contrast. He ended up developing acute on chronic kidney injury and a generalized pustular eruption, and then skin biopsy confirmed that he had AGEP. So treatment of that particular eruption was to avoid whatever drugs he was on, stop whatever he was on, and it cleared with some cortisone. So this is what your acute generalized exanthematous pustulosis looks like. It looks like an all-over eczema. Patients can be erythrodermic. They can have temperature instability. They can have blood pressure instability. And then you see these smattering of very small pustules. And as the pustules heal, the skin desquamates. So just remember this little picture that's here in this red box of the skin desquamating or peeling. So in his case, there were a number of antibiotics he was exposed to, as well as the IV contrast dye. So I tested him to what the MedSafe clinic said were his exposures. This is removal of some patches at 48 hours. And then this is a final reading at day 8. And where those 2 green arrows are, we're just starting to see little erythematous papules, a little bit of a close-up for you there. So going to keep going here. This was his piptazo. And then we tested to, again, a number of other antibiotics and his IV contrast dye. And these are his reactions at 48 hours to the IV contrast dye. We had 2 different dyes that he used. We tested them in different dilutions. And at 48 hours, look at what the skin looks like. So it nicely replicates that desquamation of AGEP. So again, in this patient's case, I had to get my compounding pharmacy, mix things together, dilutions, aqueous, petrolatum. And an interesting thing here is the aqueous form of the piptazo he did not react to, but the petrolatum form did. And it has to do with the hapten, or the allergen, being able to pass through the epidermis into the dermis to present itself to the antigen presenting cells. Nowadays, we have, did I skip somewhere? Yeah, nowadays we have standardized medication allergens. So this is new in the last year. We have a number of medications that we have in our fridge, stabilized at an appropriate concentration, already tested, aqueous form, petrolatum form. So we have a number of them we can choose for. So again, in the patients that I get referrals from the MedSafe clinic, they've done a very thorough job of looking at all their exposures. There may be a few, like meropenem is not on there, and I have a patient coming in. In fact, the patient I showed you with a below-knee amputation having his IV contrast dye reaction. Well, he just recently was seen again and was given IV contrast dye and Pip-Tazo and ended up in the ICU and very unwell. Anyhow, he survived. And Dr. Mack has said, hey, can we just test to a few other things so that we can make sure he can tolerate those in the future? And somehow something got missed saying allergic too, don't give. So a little bit of, I'm not sure how that got missed, and either is Dr. Mack, but we're really happy to have these standardized allergens that we can use to test in the medication realm. So another case of acute generalized exanthematous pustulosis. I can only see people here in the audience, but are there people in the audience who've seen patients with this eruption? Yeah, so we've had. You'll see it. It's not uncommon. So a 31-year-old man, he was known to have a seizure disorder. He had a sore throat and was prescribed clindamycin. He was later found to have COVID infection. And throughout all of this, he was also given an exposure to cephalexin as well as meropenem. So he developed DRESS-AGEP overlap. So he had the lymphadenopathy, he was feeling unwell, he had a fever, he was erythematous, but he also had some pustular eruptions as well, and he was admitted to hospital. A little note on him is previously in 2016, when the seizure disorder was being figured out, he also had DRESS, the drug eruption with eosinophilia and systemic symptoms in 2016 to phenytoin. And he was seen at the MedSafe clinic. They did the HLA testing, and HLA-B5101 is a marker for phenytoin sensitivity. So most of our neurologists, some of our psychiatrists know that before people are being put on these anti-seizure medications, they should have their HLA testing done to prevent these severe allergic reactions. So here he is, patches on that arm of the different antibiotics he was exposed to at 48 hours. You can see that there's just a little bit of erythema there, but at day 8, a really nice replication of his papular, almost going to pustular eruption to clindamycin. So helped sort out which of the drugs that I took, of the multiples I took, might have caused that. Again, an acute generalized exanthematous pustulosis, 62-year-old woman. She had dental implant surgery, and she told me it's routine for the dentist to then put people on oral amoxicillin for a week and to give them a chlorhexidine mouthwash, preventing infection, I guess, is the role of those. So 3 days later, she presented with a widespread eruption, hospital admission, biopsy proven AGEP. She was patch tested to a number of things. She had some amoxicillin in that exposure, but we wanted to know if she could tolerate cephalosporins. And her dentist had said he'd seen allergic reactions to chlorhexidine in the form of a delayed hypersensitivity reaction, not an urticarial one. And I tested her both to the pink chlorhexidine as well as the clear. In the pink chlorhexidine, there's a dye in there, and some people are allergic to that dye. So this is the extent of her AGEP. It was 95% of her body. It was almost to the point of blistering and quite purpuric. She had quite a dramatic presentation. Of course, she was a lawyer as well. So this is a patch testing I did. Patches put on day 1. 48 hours later, you can see already a little hue of red, maybe a little hue up there. And then this is her a week later, and she's got almost a vesicular eruption. This is amoxicillin, and this is dicloxacillin. So again, it helps sort it out for her. And I tested her to other cephalosporins. So in the future, she can take with some comfort that she may be able to use those medications. And when we asked her, she had had previous amoxicillin when she was younger with no problems. And then she developed the allergy. And that's the way it goes, right? Multiple exposures to things, you're going to develop an allergy potentially. So I'm going to move on. How are we doing here? Only 18 minutes. I can talk slower then because we've got all lunch. I can take a pause and ask any questions about that severe cutaneous adverse drug reaction testing. Yes.
What's the timeline after they've had an AGEP to when they can do the patch test?
Okay, so good question. The question is, what's the timeline between them having AGEP and when we can do the patch testing? Usually within 6 months. So we need to have the hyperpigmentation there because it helps us to realize where to put the patches, but we need them fully clear of their erythema, their itch, their pustules. So somewhere between, it's usually 3 to 6 months later. Any other questions from the in-person audience? Anita?
How common is it to get on the hands and soles of the feet? I was surprised to see
Yeah.
that, and the purpura, that was actually
Right.
terrifying. If you could repeat it. 'Cause I don't know.
So the question was, how common is this? Where we've got lesions on the palms, she did have some on the soles, and very purpuric. Not common. I can't give you a number, but this is not common. And I think in her situation, she was very stoic. I mean, she had a lot of rash, but didn't necessarily go right away. And it only took her 3 days to get to this, so it was quite severe and serious, and everything went quite well. And her skin went to completely back to normal, the amazing ability of the skin to heal, not a mark left on her except the biopsy site scar. Are there any questions from Zoom?
Yes, please.
Oh, so how do we put that back on? Someone's going to help me. So hold on, Zoomers. We'll see if there's, and you can teach me what to do. Okay, I have unmuted. And so are there any questions from the audience virtually on Zoom?
Yes, please.
Okay, introduce
Hi,
yourself.
Yeah, I'm Alex. I'm an internist. I recall a pretty dramatic case of what was eventually biopsy proven AGEP shortly after I completed my residency. And I have a two-part question.
Okay.
First off, if you don't mind just commenting on the potential side effects of cyclosporin and how much you actually use it for, I guess, symptomatic improvement. And the second part of the question would be, I didn't realize that there could be a significant increased risk for further development of DRESS for patients who might have an AGEP type reaction to an agent. And certainly a lot of patients would avoid those medications regardless because of how symptomatic they get from AGEP. But is it worthwhile to tell them that they're an increased risk for systemic reactions and DRESS if they continue to have exposure to the agent?
So I'm going to clarify, and I'm going to answer the second question first. So that patient who had that DRESS AGEP overlap, that is unique. And AGEP did not transform into DRESS. He happened to have two separate things going on. So we do not see AGEP morph, progress, transform into DRESS. So that is not a common entity. He was a unique patient, happens to be a dermatologist, and we get the unique things going on. So his situation was rare, and we don't often see both of those things at the same time. He just happened to present in a unique way. So in general terms, DRESS will not transform AGEP will not transform into DRESS. Different pathophysiology of what's going on with the drug eruption. Let's answer your first question. Cyclosporin is awesome. And when we're treating a drug eruption, we give doses over a very short period of time, 4 to 5 milligrams per kilogram, daily dose divided BID, might only need it for a week, and then you stop. So you will see us use that in SJS, TEN, a lot of these severe cutaneous adverse reactions. Of course, in people with renal compromise, it has to be renally dosed, but it's not contraindicated. And you had asked what side effects. Okay, they might get a little hypertensive, nausea, vomiting, that sort of stuff you get with cyclosporin, but it's on for such a short period of time that very quickly they're taken off the drug. Any other questions on Zoom? Okay. Is it okay if I leave them unmuted? Okay, we'll leave them unmuted because they're quiet. All right. So we're going to go on here. So around the surgical procedure, allergic contact dermatitis, and what are common allergens. So anywhere I've put a little underline, this is the name of the dermatology resident who currently is a dermatologist practicing here in BC, Dr. Jamie Phillips. And on his scholarly project, he worked with a few medical students, and this is what they published in our Canadian Family Physician. So the approach to allergic contact dermatitis caused by topical medications. This is where they used our REDCap database. And they went into that database and said, okay, in all the allergen testing that we do, let's look at these topical medicaments and let's see how common contact dermatitis is to it. And what you might notice if you're quick with math is 50% of the people that we found in our database who had contact allergy to a topical medication were allergic to a topical antibiotic. And for those of you who pay attention to what we have over the counter, bacitracin, neomycin, and polymyxin B are very much over the counter, accessible to the general public topical antibiotics. So we had a case. This was a great, 4:45 on Friday afternoon. Gillian, can you see this person quickly? Sure, come on in. So this young woman had a elective mole removal from her preauricular area. And the habit of the surgeon was to say, post mole removal, apply polysporin ointment to help it heal. I'd say that's an admission of failure, thinking you're going to get an infection, but that's okay. That's just a little, good. We had some laughs. Anyhow, so she came to me for we treated her dermatitis, and then she came back and had patch testing done. So what I will always do is I test to their own product. So this is polysporin ointment that she used, and I tested her to the 5 common ingredients in that product. And we can see here, final reading day 8, that's her polysporin, and that was the bacitracin in the polysporin. This is her just a week later with us treating her with clobetasol. Oh my, clobetasol ointment on the face? Absolutely. You're just using it for a week. You quickly calm it down and then you stop. So this is where we wrote a little note back to the surgeon and encouraged them just to use Vaseline petroleum jelly or maybe Aquaphor ointment as their moist wound healing technique after the surgical procedure. Another case from one of our general surgery colleagues here, again, late on a Friday, giving a call saying, could you please see? So she'd had a thyroidectomy, and the procedure post-op was to slather with polysporin ointment, cover with a bandage, and keep it on for a week. So a week later, when they took it off, this is what it looked like. So again, just a week later, treating her with some clobetasol, I went on to patch test her, and she ended up being, again, bacitracin allergic. And again, we just encouraged the surgeon to use Vaseline jelly post-op instead of the antibiotic. And it's not only the surgeons who do that. This is a laser dermatology colleague of mine directing his patient to put polysporin on her lasered spots. And then she ended up in his office, not my office, with this eruption. Eventually, when we patch tested her, so polysporin ointment, bacitracin, very common theme. And those of you might also know that the triple creams that some people prescribe, there's a corticosteroid in it, there's an antifungal in it, there might be not 1, but 2 antibiotics in it because they're really not sure what the rash is and we'll just throw everything at it. A number of those will have bacitracin or neomycin or gentamicin in them. So careful with those. So this is Dr. Harry Liu. He's a 5th-year dermatology resident, ready to graduate. Will be practicing in British Columbia. We're very excited to have him join our colleagues. And he submitted this to our Canadian Society of Plastic Surgery journal, Plastic Surgery. So recurrent allergic contact dermatitis to bacitracin, again, used in pocket irrigation during breast reconstruction surgery. So this is a woman who, at a young age, diagnosed with this very advanced breast cancer. She had 3 breast surgeries over a short period of time. And after each surgical procedure, she developed a rash, first localized around the breast. And then after the next one, it kind of extended down to her belly button. And after the next one, it involved her genitals and her underarms and was traveling up her face. So she was labeled after each surgery allergic to the IV antibiotic used pre-op and post-op. So labeled as can't take that, can't take that, can't take that. She did end up going to MedSafe Clinic, and all of those were found non-allergic. After her 3rd surgery, they consulted dermatology and said, can you guys come in here and look at this? And the thing about looking at morphology, all of her eruption was eczematous, small, tiny little vesicles, as opposed to when we have, allergic reactions to drugs that are IV. Sometimes you don't see the eczematous component of it. It's just erythema. So seeing that it was eczematous, they thought, we should consider allergic contact dermatitis in this. But I didn't put anything on my body, doctor. So when we reviewed the surgical report, the surgeon with the pocket irrigation, as well as soaking the implant, in a double antibiotic solution of tobramycin and bacitracin solution. So that's after the fact when we actually found out she was bacitracin allergic, and that's where the problem was. So she had basically localized allergic contact dermatitis in a delayed fashion, and then with each successive surgery, she auto-eczematized because she didn't rub any of this antibiotic anyplace else on her body. And this was sort of at her worst. These are photographs that she allowed us to both publish and to talk in talks. So extending down to her body, and the little white arrows, you probably can't see it, but they're small vesicles there. So little micro vesicles, think eczematous, think about what's been put on the body or in the body. So this was her patch testing. We normally test to 80 allergens. She brought in dressings and other things that they'd used in the breast surgery. And really, she came up positive to bacitracin only. You can see the 48-hour and day 8. So it was a good solve. She was a very happy patient after that. And I'm not sure if the surgeon is changing their routine, but at least they're going to keep in mind, aha, if that happens again, maybe we should test for the contact allergy. So this is another through MedSafe patient. She was in ICU with the erythroderma, hypotension, a whole bunch of things going on. But in that erythroderma also found to have an eczematous dermatitis. And she was getting pacemaker or some sort of cardiac implant put in, and part of the surgical procedure was to irrigate the pocket with bacitracin as well as to soak the device in some bacitracin. So going through all of that history, again, found to be allergic to bacitracin on patch testing. She was also one of the patients who was contrast dye allergic as well. And they think the contrast dye exposure may have caused all of her hypotension and all the really bad stuff. But again, in our testing here, so day 8, we can see this was viscopaque and omnipaque. I think those were the two that we were testing her to there. Okay, so contact allergy to lidocaine. So you know that lidocaine can develop or present as 2 different types of allergic reactions. So there's type 1 allergic reaction. People get lidocaine in a whole bunch of procedures. They become tachycardic, they become hypotensive, and some of them crash quite quickly. That's not the kind of allergy I'm looking at. I always say to my patients, dermatologists don't do death. You know, we don't do that quick acute stuff in the office. We do stuff, we take a biopsy, we read about things, we think about it, we see them 2 weeks later, and sometimes problem solved. So we're looking here for contact allergy to lidocaine. And again, the underlying names there, Dr. Irene Kostanseva is one of our Mohs surgeons. So she does many, many, many surgical procedures on many, many people and has come across this in her work, also when she was a resident with me. And you guys might know Dr. Derek Toe. He trained in Ottawa and he's a dermatologist in the community in Coquitlam. So this is their publication as well as a poster presentation looking at lidocaine contact allergy becoming more prevalent. And if it becomes more prevalent, it's going to be a problem later on in the life of the patient when they have a dental procedure, when they've got to get their skin cancer removed, after their carpal tunnel syndrome, and you put in local anesthetic for pain control afterwards, they wake up from the anesthetic, they've got their lidocaine there, and a week later, they've got a rash. I had a lovely patient who came in to see me after multiple surgeries and multiple post-operative infections. The way she described it, 4 or 5 days later, red, itchy, bumpy, and she had carpal tunnel surgery, she had breast surgery, she had nose surgery. She was also a lawyer. She was very unhappy at the post-operative surgical infections that she wanted to sue everybody for. And I said, hang on, let's step aside a second and let's see if it could possibly be something else. And she ended up being one of my contact allergy, delayed type 4 hypersensitivity to lidocaine. And she said, but come on, I was under general anesthetic. Nobody gave me topical lidocaine or local anesthetic. And in reading some of the surgical notes, post-operative pain control was because they infused some lidocaine in there. So she was very nice. She brought me flowers and she said, I should probably go apologize to those surgeons because she wasn't very, you cause an infection. So lidocaine allergy becoming more prevalent. So here's a patient over Christmas. He was building a new crib for his baby. He developed a blister on his hand from all the hard labor. I think he was an accountant. He went to the pharmacy to get something, to put something on it to help it heal. And he presented to the emergency room 5 days later with a severe blistering hand eruption. So when you guys see this in the emerge, you're not going to think contact dermatitis first, okay? It's blistering. It's quite extensive. What's going on here? Well, only thing I'm going to ask you to do is when you see blisters or vesicles, just ask if it's itchy. And if there's any component of itch, because you'd think this might be very painful, if there's any component of itch, step back and ask around, what did you put on? And I don't mean today, I mean a week ago. What were you putting on the area? And if you hear the word polysporin, consider it as a topical allergen, okay? So he was put on IV antibiotics for 5 days by the emerge, coming in, because they assume cellulitis, and good, treat cellulitis because you don't want to die from sepsis. I understand that. But on day 6, they asked Derm to come and have a look. And then it looks like we come in and we're the heroes with the cape, but we're not. It was just, look at the morphology of this and ask about what he put on it. So after all was said and done, and I did my patch testing, he was found to be allergic to lidocaine, which is in this product called Polysporin Complete. Okay, keep that product in mind. Black gold. Emergency room visit, cut my thumb on a tin can, went to the pharmacy, and honestly, same thing. Wanted to put something on it to help it heal. She presented to the emerge 3 days later with a severe necrotic blistering eruption on her thumb. She was given IV antibiotics. She was debrided by plastic surgery and then told to put topical antibiotics on the debrided area, and it got worse. So before the second suggested plastic surgery procedure, a dermatology consultation was arranged. She was in Fort St. John, I think. So the Edmonton dermatologist said, what have you been putting on this area? Oh, I've been putting Polysporin Complete on. Okay, stop. Let's give you some clobetasol. And that was her story, but let's just take you through it. Again, when you're in emerge, say you're doing some covering, and you see this, you're not going to think allergic contact dermatitis. What might you think? Well, a dermatologist might think ORF, if you remember what ORF is. It's a viral infection from sheep, a cutaneous lymphoma, maybe a skin cancer, some really bad bacterial infection that's going to end up like flesh-eating disease, something terrible, necrotizing fasciitis. So that was the approach to that. This is following the debridement of that. And this is following putting her antibiotic back on it. So in her case, she came to my office actually. We tested her to 5 different polysporin products and the 5 different ingredients in those polysporin products. At 48 hours, she was reacting to the 2 polysporin products that contained lidocaine, and she was reacting to lidocaine. So at the 48 hours, even worse. As you know, these type 4 hypersensitivity reactions will get worse before they get better. So again, another case. Lidocaine allergy secondary to Polysporin Complete. I recently spoke with one of my colleagues in Toronto. A man went on to have his finger amputated because of that kind of reaction, thinking that it was necrotizing fasciitis and he was allergic to his Polysporin Complete. So just remember it, just ask about it. When you see something, did you put anything on it? No. Hey, not today, think a week previous. So this is her after her second debridement, or third, I should say, and then this is her scar afterwards. All right, last thing I'm going to talk about, emerging allergens, okay? So lidocaine becoming more prevalent, and most people know of the aesthetics and cosmetic industry. So this technique here with an eyebrow is called microblading, and they put some tattoo ink in and make eyebrows look like eyebrows should look, I'm not sure, but they use a topical lidocaine. And then unfortunately, this kind of thing happens, okay? Lidocaine is also used in other procedures. Now, I don't do any cosmetics, and I'm not sure if that's how her lips are supposed to look, or if she's having like angioedema to something, but lidocaine is used in those situations as well. So question, do patients with contact allergy to local anesthetic need intradermal testing before a surgical procedure? Scenario is older woman, multiple basal cell carcinomas on the face. She's had multiple Mohs procedures. And at about a week after each Mohs procedure, she gets an infection. Unfortunately, she didn't go back to the Mohs surgeon, who's a dermatologist. She went to her family doctor, gets put on antibiotics each time. So when the Mohs surgeon was hearing this, they kind of said, pause, let's check. So she ended up being contact allergic to lidocaine. So when we talk about contact allergy, a topical versus intradermal test. So when we do patch testing, the allergen, the lidocaine, the hapten is sitting on top of the epidermis. It gets absorbed through the epidermis down into the superficial dermis. It sees antigen presenting cells of different sorts, Langerhans cells in the epidermis, dermal dendritic cells in the dermis, and a reaction might happen. But what if we took a needle and completely bypassed that epidermis and deposited that lidocaine in the dermis? Would that person still have a type 4 hypersensitivity reaction? So in this study of patients, we had 8 of them that did let us do intradermal testing. All 8 of them were contact allergy topical, but only 3 of them showed a delayed hypersensitivity reaction to this lidocaine put intradermally. So again, the question is, do we need to do this? And from, I talk about this a lot. So only in the situation where people have multiple or have had multiple experiences, multiple moles removed, the rest of it, I will do some intradermal testing looking for delayed type 4 hypersensitivity. It's mostly the dentists who send me all the different canes and local anesthetics that you use. I test the people, patch test as well as intradermal test. I'm not looking for anaphylaxis. I'm looking for this delayed hypersensitivity. Is it life-threatening? No. Is it uncomfortable? Yes. So we can guide the surgeon in what they can use. All right. So I'm going to come back to my key points now. Contact dermatitis clinic, we're here to stay and thrive. So we used to be every year hoping we got a donation, hoping we got a good donation. Now we're a line item in the budget, and I'm looking for exit strategy and planning succession. So anybody who's interested in running a contact dermatitis clinic, I will help teach you how to do so. I've probably got another 15 years in me if the hospital wants to keep me, but we still have to plan ahead. Yes, patch testing can be a useful tool in helping in the diagnosis of scar, mostly though with AGEP and fixed drug eruption. So what I say to the patients, and I have tested some SJS patients, some TEN patients, some DRESS patients, I say if the test is negative, it means nothing. It's a very low sensitivity test. But if it's positive, it might mean something. That's about as much as I can give to them, that if we find a positive patch test reaction, we would encourage avoiding that. And with the MedSafe clinic, they do the HLA testing, they do the lymphocyte toxicity assay, and sometimes we get multiple hits of positivities, and then we say, definite, you need to avoid this allergen. And then in the peri-surgical setting, remember how I said it can take a year to see me? These peri-surgical referrals, I expedite, I see them quickly. I have a number of orthopedic surgeons who take a history from a patient and say, oh, you're allergic to metal? Let me send you to the contact dermatitis clinic to make sure you're not allergic to the metal I want to put in your body. Now, metal hypersensitivity syndrome, that's a talk for another day, and I kind of left that one aside. But that's the type of patient I see. Cardiologists have sent me patients. The breast surgeons have sent me patients. Neurology for the neural implants. So I've had a number of peri-surgical contact derm problems that were solved. All right. So that ends my portion of the talk. Can I entertain any questions here in the audience? In person?
I do a lot of procedures and the lidocaine. So how often do you actually see it in the hospitals?
So the question was, how often do I see this lidocaine hypersensitivity reaction in the hospital setting? Right now, I've had no hospital-based patients admitted to hospital needing to answer that question. It's mostly been outpatient dental services, the surgical services for skin cancers, and I've seen some orthopedic surgeons and a number of these aesthetic clinics as well with the different aesthetic procedures that are being done, but never a sick in-hospital patient. Any questions from Zoom?
Hi, Dr.
Okay.
Gannes. I don't know if you can hear me.
I can hear you well, and you
Hi.
can introduce yourself.
Okay, this is Angelique Barlis, allergist out in Port Moody.
Yes.
I've talked to you before. I do patch testing in my clinic. It's interesting that lidocaine allergy case. I actually just recently had a patient who reacted to topical lidocaine, and we ended up doing patch testing. She was positive to it on her patch test. And she's actually scheduled for a LEAP procedure. And the OBGYN was wondering what type of injectable local anesthetic could be used. Just in terms of just the previous case that you talked about, what would you recommend for them?
So you can't really, everyone thinks, okay, well, if it's a cane, an amide, then let's use an ester. And that doesn't really hold true. So sometimes you can still use an amide. So what I've said to my dentists or my surgeons, what local anesthetics do you have in your facility that you can use on this patient? And we do an intradermal test to it. So if they have bupivacaine or they may have benzocaine, so the surgeon will send me the samples in little tubes, and I do an intradermal test looking for a delayed hypersensitivity reaction. And I also test the lidocaine at that situation. So I don't know if you did an intradermal test and showed she had a type 4 hypersensitivity to it, because as you can see, not everybody will.
Yeah, I didn't end up doing intradermal testing, but yeah, that's a very good point. That might be something that she would benefit from. And then for intradermal testing, reading wise, is it the same type of reading as you would do for patch testing?
Correct. So I do a 48-hour reading, and then I do a delayed reading. And normally if we're just doing one, I have patients send me pictures. I don't need them to come on back. So yeah, it's the same kind of, we're looking for a delayed type 4 hypersensitivity reaction, which will present as dermatitis. So infiltrated papules, vesicles, maybe bullae if it's really bad.
Okay, awesome. Thanks so much.
You're welcome. Anyone else? Okay.
Thank you so much.
Oh, you're welcome.
Excellent. Thank
Have
you.
a good day.
Actually terrifying. These things, like, we use lidocaine center, like people
Yeah.
over the counter, all that, all this morning.
Yeah, I think the big take-home message here is polysporin is ask about polysporin and ask about tea tree oil. Those are two big winners. Tea tree oil is not a good product for some people. So tea tree oil gets put on everything. And so you see someone with a vesicular eruption somewhere and, did you put anything on it? No. How about last week? Oh yeah, my neighbor told me to put this tea tree oil paste on it. Or, oh no, I just used the over-the-counter one, the pharmacist. No, it wasn't called polysporin. It was, oh yeah, it was a Life brand triple antibiotic, which is just like polysporin. So you ask them and ask them again, and you ask them again, and you ask them again.
Those lesions or the itchy. That's actually a hint to the
Correct. Correct. Now it could be painful as well, but ask about that itch, and even early on. And if you get any history that there's itch, think about contact dermatitis. Well, thanks for being here. Yeah.
Sorry about this. So the dentists who refer to patients, like they're injecting lidocaine for nerve blocks, etc. So these patients do that just localize.
Yeah, no. So what they end up getting, and so I can't accept a referral from a dentist. It comes through the primary care provider saying, adverse reaction after dental procedure. So they have their procedure, and maybe 3 or 4 days later, their cheek swells, their face gets all red. They get, a vesicular eruption down their neck, and then everyone's like, oh, it's a bad infection. Let's give them more antibiotics. And then eventually they end up in my office. So it's a delayed hypersensitivity reaction. The mucosa, when it shows a delayed hypersensitivity reaction, it might just be a little bit swollen, but it's really that they get sort of a full face. So in dentistry, the local anesthetic, but more importantly, the acrylic molecules that are used for their caps, their crowns, all that kind of stuff they're putting in there. And the surgeons in our group know that acrylic molecules are also used in knee, hip, etc. That's the bone cement. So just a little aside, we have these young people getting acrylic nails. They get acrylic glue on eyelashes. They get sensitized to their acrylics. They go to have their dental procedure and their face blows up. And when they're 60, they're going to have problems with their acrylic cement. So it's an unfortunate, again, emerging allergen, and it'll be a problem in the future. So I have a woman who's very allergic to all the acrylics, but she has such bad dental problems. The dentist pre-treats her with prednisone and carries her over for 2 weeks, and she's fine. Because once the acrylics harden and become our plastic on our nails, they're no longer allergenic. It's the monomers in the process of hardening into a polymer that releases the hapten, and that's when people react. So knee replacement, patient comes, they've got this big rash above and below their knee. 6 weeks later, it's gone. What was it? It was them reacting to the acrylic glue in the cement, but once it hardens, it's no longer a problem. So the nail stuff, the eyelash stuff, different situation because they repeatedly get things, right? They're repeatedly getting their nail stuff done with the UV
And at
light.
one time they could react.
Yeah, and once they've reacted, they react forever. So they end up coming in with dystrophic nails, they peel, they break off, they split, and they often have a dermatitis around the tip of their finger. And they're stuck on those nails, man. They want them, you know? And so we have to say, nope, can't get those anymore.
And eyelashes?
So eyelash glue, right? So you stick eyelashes on. They either have a latex-based glue, a formaldehyde-based glue, or an acrylic-based glue that they stick a lash on your own lashes, and they get a very significant periocular dermatitis. So I get eyelashes put on every once in a while. I got to try this stuff out, right? Never did the lips though. And just down the street, Mink Lash Lounge. When I went to see them, they said, we'd like to offer you a patch test to make sure you're not allergic to the glue. And I was like, way to go. Awesome. Let's do it. How do you do it? You know, and then I told them who I was, and so very good. I was very happy to see that in the industry. Totally recognize that. I mean, if one of those clients come back and they're all puffy and swollen and icky on their eyes, so it's out there in the community to know. And they did it exactly like I would. They had a little circle, they put it on. I didn't get tested, but that's fine because I've been tested before. But I thought that was great that they offered their clients that service. Yeah. Okay.
Okay, thank you so much.
You're welcome.
That was really great. It's nice to see you again.
Yes.
Well, how does silence?
Does it happen so often?
Oh, yeah, it was just,
Quickly,
it's the incoming here.
Oh, that.